when there's a lot of trauma, there is no consolidation of memory, but the nonverbal consolidation of this emotional memory registers. So you can't put words to it. That's why trauma takes away your words. If you can't put words to it, you can't understand it. If you can't understand it, you have no control over it, and then it takes over you.
Yep.
So the hippocampus is just really important to keep in mind. The reason we calm the environment down, calm the nervous system down, is so you can stop and verbally remember what just happened. A lot of kids will say, I don't know, I blacked out.
I
Really
blacked
don't
out.
know.
Yep.
Yeah, and those are the moments we really need to hunker down and create that calm environment. Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Okay, so we do want to spend a little bit of time expanding on how trauma presents in children, because I think we often see that these kids are defiant, they're aggressive, they're throwing things, they're really labile up and down and explosive, and they'll be labeled as oppositional defiant or intermittently explosive. And frankly, I don't think any of these diagnoses that's been added in the last 10 years is meaningful or helpful at all, because it really doesn't go into the underlying problem. There's also some other diagnoses that have come up that's not in the DSM, like pathological avoidance, that's been going around.
Yeah, pathological demand avoidance. I think it can be useful in a way because it removes behavior just from the world of behavior and does try to say that this is a reaction to stressors and anxiety and a fear response of losing control. So, in a way, it's helpful because it moves away from your child is just being defiant. What I hear a lot is my kid is acting like a narcissist. It's all about them. Like if anything changes that impacts them, they become very upset and take control of the whole situation. And it sort of reframes it as this is a reaction. This is a response. So in a way, I think that's helpful. But it also doesn't speak to the real etiology of it, where it's really coming from, which for a lot of people can be trauma. It doesn't have to be trauma, but can be trauma. Mm-hmm. And to not even really consider that, you're never going to get to where this is coming from. And so it's going to be so much harder to treat.
Mm-hmm. And I think that's the biggest thing, is that if you are thinking that it's more oppositional and defiant or some sort of behavioral thing, the treatment can be a very structured behavioral intervention. But if you're not addressing that core etiology, it feels like patchwork. It feels like a Band-Aid. But once you address some of the underlying issues like trauma or like anxiety, social anxiety, whatever it is, then you can move on to the behavioral interventions. Especially the younger they are, the symptoms look like regression. So they'll be clingy. They'll want to be with the parent all the time. They will lose some of the skills they've had before. So if they used to be very good at writing or reading, they are no longer good at it. Their grades decline. There might be a lot of physical complaints like headaches and stomach aches. There's more serotonin receptors in your gut than the rest of your body. And so we hear about the stomach aches a lot. These are some signs of trauma and PTSD in children that we don't necessarily see in adults, because with adults, we have prefrontal cortex activation. We know what not to do to function as a person in the world.
And even then, sometimes you will see your self tells you you're anxious, not through explicit worries, but through physical symptoms or vice versa. And I think trauma can certainly come out the same way. And I agree, it's definitely more likely in kids, but you do see it in adults too. So I think one thing that is helpful to be explicit about is the idea of a differential diagnosis. So whenever we see a patient, a new patient, this is what we take into consideration, is where are these symptoms coming from? And I think one big failure of the DSM is that it is built primarily, or was built primarily, for research purposes. So it has a list of criteria that are inclusion and exclusion criteria for consideration for a diagnosis. But just because you meet all of the inclusion criteria or don't meet all of the inclusion criteria doesn't mean that that is the only thing taking into consideration when you're making a diagnosis. There are lots of other things that could be responsible for the symptoms that you're seeing. And that's our job, is to go through it. So many times someone will come in with a set of symptoms and will have a family member or something similar, or a friend, or they'll do some Googling or whatever and say, I think it's this. And it's possible, it's certainly possible, but there are other possibilities, and that's what we try to tease apart. And it's so common. I don't know why that trauma is missed and not covered or thought about as a core underlying potential cause for so many of the symptoms we see. ADHD, distractibility, hyperactivity is so similar to scanning your environment for threat and hyperresponsiveness, or even depression, being emotionally shut down, withdrawn, isolated, is so common to the avoidance behavior that goes along with PTSD. So I'm not saying everything is trauma, but I'm saying that in an evaluation, at least considering the full range of possibilities, of which trauma is one, is so important. And I don't think we do it enough.
Yeah. I think a lot of it has to do with the stigma. I think ADHD has been widely accepted, and I think, funny enough, because its treatments are almost immediately effective, the medications, stimulants, Adderall, Vyvanse, Focalin. So when you have an answer to a problem, that immediately the stigma is removed because you fixed it. Oh, you're done. Forget about the fact that you have to learn skills to organize things, but at least in the interim, the medications help. But when you don't have that immediate fixer-upper, and trauma takes a long time, months, years of therapy, I think people give up or maybe feel that it's just not worth investing all that time. And so there's a temporal element to increasing the stigma of trauma, depression, anxiety, compared to something like ADHD.
Right.
Yeah.
Yes, I totally agree.
Yeah. So going back to how trauma presents in childhood, I was remembering that at some point in training, I had learned about developmental trauma disorder, but it's not in the DSM. It is something that a lot of people who work with traumatized kids see, because it's like this constellation of symptoms of, regression, agitation, inability to pay attention, and just severe mood swings. And it captured a lot of that. And I think it eliminated the need for other diagnoses like oppositional defiant disorder. And they submitted this diagnosis to be included in the DSM, but it was denied in 2009. And so I'm wondering about, Dr. Kelly, what you think about this, because I can see that it's very vast as a diagnosis. It captures a lot of things at once, and maybe it's difficult for insurance companies and researchers to quantify that. But at the same time, clinically, I feel that it's a very important diagnosis to consider, especially when it's this like chronically invalidating home environment that is not quite abuse, but it's emotional neglect or it's verbal criticisms that's happening over and over again. And it completely wipes out your self-esteem, and then therefore you're not able to go out into the world confidently. And so I just wonder what you thought about that.
I mean, I think that the trajectory of this diagnosis and its inclusion or exclusion follows a similar trajectory to lots of other diagnoses, like complex PTSD, right? That the purpose of the DSM is for research. And so if something is clear and definable and consistent and replicatable, then it makes it into the DSM. The DSM actually does not like things that are more vague or customized to the person or can seem overly inclusive or sometimes even under inclusive. The discussion about autism and removing all the subcategories of pervasive developmental disorder and turning it into a spectrum. I was going through sort of my first years as an attending while that discussion was happening. And I was working at Hopkins, but that was affiliated with the Kennedy Krieger Institute, one of the world's premier organizations for the diagnosis and treatment of autism. And just the politics and discussions and everything that was involved in that, it was tremendous. So I can't imagine what the trauma world is going through. And so I might be speaking out of turn, but it reminds me of complex PTSD is where I'm going with this, which is a recognized diagnosis in ICD-11, but not in the DSM, partially because it overlaps with a number of other diagnoses, that it's hard to objectively separate out because it's essentially, are your symptoms from a traumatic experience, and proving that causality is so difficult. I mean, that's the whole point of treatment, is to figure that out. But for a study, if you have 200 people, making sure that for each one of them, that's the etiology, that's so hard to do. So it's not that we don't recognize it as clinicians. I think it's for other reasons that the DSM just finds it too complicated to be included. I think that developmental trauma disorder, the complex PTSD, I'm really trying not to get on a soapbox here against the DSM, but
Yeah.
so the way I was trained, it takes into account the DSM, but the formulation is based on the perspectives. So it looks at someone through different lenses and different possibilities. So is this someone's biology, something that they've inherited, something that's in their genes? Or is it based on their life experience, something that's happened to them? And that's what's causing the etiology. And they're not mutually exclusive necessarily. It's a theoretical framework through which you can view the same patient. And you can sort of take those hats on and off and look at somebody through different ways. It doesn't have to be one or the other. It makes room for that flexible approach, taking different things into account. So the same person can be sitting in front of me. In that framework, it's easy to go back and forth and think about, well, is this ADHD? Is this trauma? Is this anxiety presenting a different way? Is this behaviorally reinforced? Is this part of their behavior and they're in a behavioral system where this type of behavior is really useful in that system? And you can think about all those different things all the time with the same patient and work back and forth about, well, this treatment would address this. Let's see how this treatment goes. Okay, maybe that was less successful. Maybe we need to bolster that up with something that focuses more on behavioral reinforcements. And you can keep that all in your head at the same time. So I think it's a more comprehensive approach to saying, all right, what I'm seeing in front of me, can I see it through this lens of developmental trauma? Or can I see it through this lens of behavioral reinforcement? Or can I see it through this lens of the biology of the person? And how do all of those fit together to create the picture that's sitting in front of me? And how do I treat all of those? I've gone way off topic, but this is
No, I think it's very relevant. No. I think it's spot on.
Well, because you asked a simple question and I should have a simple answer, but it's not a simple answer.
Right. It's a loaded question. No, it's like the framework, like attachment theory is a framework, it's a lens through which we see things, and developmental trauma can be a framework, and complex PTSD as well. And I think that the integration of all of these different approaches, it's really relevant, because I think we can sit around and theorize all we want, but when it comes down to the work, I need some sort of map on which direction to go. And sometimes the behavioral approach really guides, because I'm realizing, okay, we really got to act on this. And then sometimes the very supportive and compassionate approach is helpful, just to get it out and talk about it in an open and safe space, which then contains the emotional explosion in that moment.
Yeah, like disorganized attachment. It's not in the DSM, but we use it all the time when we're talking to patients, when we're conceptualizing patients. So maybe that's where I'm getting a little tripped up, because I was sort of thinking in the way you asked the question, why is developmental trauma disorder not valid? Which is not the right way to think about it. It's why is it not in the DSM, which is a much smaller world, because the DSM is not everything.
Right. Yeah. I do feel for patients though, because
Yes.
when you don't have a definitive diagnosis like that, but then there's this whole thing that whoever is working with you is using to work with you, it's hard, right? It's almost like you're not in on the big concepts. And so that's where I think it trips me up is that it kind of strips away that understanding and knowledge that the patient deserves, because then
Hmm.
they'll go and read books like The Body Keeps the Score or The Boy Who Was Raised as a Dog. That's
Hmm.
another one. And they'll figure out that, oh, all of these symptoms and the way they conceptualize it, it resonates with me so much. And then you go to a psychiatrist or maybe a therapist, and these diagnoses are not quite brought up, maybe in conversation, but not like on paper. And so it's sad to see that there's no formal recognition, but it's a big underlying current that we use all the time.
Absolutely. And I think it's helpful to stay open about that. And I know as a patient, it can be frustrating to have us as clinicians say, well, you're looking for a definitive answer, and we like to keep things open, and maybe we don't know the definitive answer. And I understand how frustrating that can be. And for us as clinicians, we come from a medical world. If somebody breaks their arm, we look at the x ray and we say, there it is. It's right there. There's no question about it. Whereas for us, it's a little bit different. But to zoom out, all of our concepts of mental health are created by us. We didn't find them in a book somewhere. We didn't dig up the DSM that was sort of sent down from heaven. Like we made all of this up. So it's all hypothesis and ways of conceptualizing problems. So one person may see things through the lens of trauma and it may fit perfectly and all the concepts line up. And
Mhm.
so it's a useful framework for treatment, but that doesn't mean it's necessarily objectively true. And that can be so hard to tolerate that ambiguity and the fact that as new data comes in, sometimes we have to change our hypothesis and we have to say, yeah, gosh, this all fits, but we add this one data point and it doesn't fit quite as well. And maybe we need to think about other causes or other potential treatments.
Yeah.
Actually, that's a good way to transition over. So, when I was talking about the perspectives and the biology side of it,
Mhm.
it's true, it talks about biology. Usually, we think about that in terms of biological etiology. So, do you have a short serotonin receptor? And so you're more set up for anxiety and depression. What we know about trauma actually is that it can work both ways, that there are some people who have a pre-existing condition or a biological proclivity to be more sensitive to trauma,
Mhm.
to traumatic experiences when they happen. The COMT genetic difference that can make somebody less able to calm themselves after a traumatic exposure, for example. But it can also work the other way. The trauma can change your biology. Going through a traumatic experience can change your physical body and even your genetics over time. So the interplay between trauma and biology is really fascinating and it can be both ways. Another thing to know about trauma and the biology that we're going to talk about is a lot of these responses are normal and natural and from an evolutionary standpoint advantageous. So when a traumatic exposure happens, your body gets ready to survive. These are all survival responses that are no longer serving you, but they're all there for a reason. So when you're exposed to a trauma, you get this surge of adrenaline, the fight or flight response, which is survival. So you get your heart rate goes up, your blood pressure goes up, you get this sort of surge of energy, your pupils change, you get a dump of cortisol, and that can happen recurrently multiple times,
Mhm.
and it can go on for a while. For better or worse, that actually surge of adrenaline in the cortical system in the brain itself, the same chemical is called norepinephrine. And it's a chemical, a neurotransmitter that we manipulate with medications. And we know it's associated with attention and with mood and with all that stuff. So, unfortunately, when some people will say if they go through a traumatic experience, they have trouble recalling it. Actually, when your body goes through trauma, that surge sets yourself up to retain everything that's happening. People talk about bullet time, people talk about time slowing down and feeling like they're hyper aware and hyper acute. that's your body trying to take all of this information in and be as attentive as possible and remember what happened so that it doesn't happen to you again. So you're sort of biologically predisposed to remember trauma. It's weird to say it that way, but it is true.
Yeah, and it's protective that way. I think we often hear people say, I don't know why I keep doing this. It's self-sabotage. But it's biologically, that's how the brain protects you. So if you are chronically having high cortisol because you've been exposed to that trauma over and over again, and once that trauma is removed, whatever the traumatic experience is removed from your life, why would your body suddenly relax? The body doesn't know when to relax or not. And so it'll keep increasing the cortisol, the norepinephrine, the catecholamines to anticipate something else that can come into your life. And this happens in interpersonal relationships, right? So you've been betrayed, you've been neglected, and that was your childhood. And now that you're an adult, you form new relationships, but your body expects that betrayal.
Yeah.
Your body expects that neglect. And so you might push people away when they come too close and you get too vulnerable. So it's a very much a biological basis for these symptoms that we see in the here and now.
Yeah, and there's a part of the brain that's sort of responsible for that, the amygdala, that people talk about all the time. It's a very useful part. Now there are lots of darlings of the brain. There's the default mode network, but the amygdala was
Mhm.
the darling of the brain for a long time.
Yeah.
Everybody talked about it because it's a little separate from what we usually think of as intellectual knowledge. It's more the emotional knowledge and the emotional responsiveness of the brain. And it sits there waiting for threat and says, "Oh, there's threat. We've seen this before. Let's respond. Let's get ready." And so a lot of those same cascades that initially came up when you were, God forbid, about to get run over by a car can come up again every time you're getting ready to cross the street because your body's getting you ready in case something like that happens again. And that's a lot of times how trauma plays back out.
Yeah. Yeah, the amygdala, I remember learning that it was an almond-sized
Mm-hmm.
structure in the brain. And that's always fun to mention to kids, right? Because then they're like, "Oh, that's small and I'm
Mm-hmm.
freaking out because of that." But you're right, it's a big threat assessment center. And in order to calm that threat assessment center down, we have our prefrontal cortex. And we've talked about this in the prior episodes as well, but this doesn't fully develop for a long time, especially teenagers. It's not quite fully online. And so when something happens, it irritates you, a lot of times you explode because the amygdala is out of control there. But the prefrontal cortex, so it's interesting. There's that logic side of dorsal lateral prefrontal cortex, and then there's the more emotionally attuned side of medial prefrontal cortex. And the tricky thing is that both have to be online. And the dorsal side has almost like no connection or barely any connection to the amygdala. And so, even if you are able to sit down and do complex math problems and, analytical things, if that medial prefrontal cortex isn't developed, you're not able to connect that emotional intuition to your analytical, linguistic, logical side of the brain. And so it's quite complicated, but all that is to say that in those moments of amygdala overpowering the entire brain, it's helpful to have a calm tone, to provide an environment that feels relaxed and safe, where it induces a sense of curiosity to learn about what's actually happening to you rather than shame, guilt, all of these other things that can further disconnect your prefrontal cortex from your amygdala. And so this is such an important point in clinical work because when I start to see the amygdala response, I will intentionally lower the tone of my voice. I will intentionally move slower and just create this environment because that is literally the intervention. Literally, in that moment, you learn to feel more grounded because your threat assessment center isn't blowing up.
It's so true. And I think a lot of our instinct, especially parents' instinct, is to compare the emotional response to the reality of the situation. but in a more forceful way, which
Hmm.
to the person going through it can sometimes feel very invalidating. It comes across as your feelings are invalid, or you have no reason to feel this way, or your feelings are wrong, which, I mean, this is survival. It's at the same level of if you hold your breath, your body telling you to breathe. Like this feels so real that to say that it makes somebody feel disconnected. And sometimes they can double down and say, well, I hear the words you're saying, but they don't make sense. So
Hmm.
I'm going with my emotions because those are what keep me alive. And so I think just taking a breath and letting somebody have a little bit of space to regulate and helping addressing it from an emotional standpoint as opposed to an intellectual standpoint can be really useful. Sometimes just playing common music, turning off the lights, whatever it takes to allow somebody's emotions to come back to baseline so that they have access to those higher reasoning centers. And then you can have more of a discussion about were these emotions about what's happening right now or about something that happened in the past. That's, I think, more useful.
Yeah. I like that turning down the lights thing too. It's literally sometimes you just have to reduce stimulation of all
Mm-hmm.
sensory forms. Right.
Yeah.
Also, you mentioned the default mode network, which
Yeah.
I was reading that traumatic memory is stored slightly different from regular memory, like non-traumatic, non-emotional memory, and that traumatic memory has a little more emphasis on the default mode network, and especially in the posterior cingulate cortex. And the interpretation of that finding was that traumatic memory is not quite memory yet. It's just kind of experiencing internally your sense of self and how it's interacting with the world. And so it's almost like the trauma, it's just being replayed and it's being re-experienced and not as a memory, because once it's a memory it's conscious, it's kind
Mhm.
of at the forefront, but when it's not, then it's re-experiencing that trauma over and over again in the posterior cingulate and the default mode network. So I thought that was so interesting because I had never conceptualized traumatic memory as like a just still experiencing going on in the mind.
Yeah, and that's so cool. And I mean, unfortunate, but cool because it becomes so central to who you are, and it makes so much sense when you think about the symptoms of trauma that to most people don't make sense. All of the mental disconnect and emotional disconnect, but also hyper vigilance and hyper alertness, and how when you're talking to somebody who's had a traumatic experience, sometimes it makes so much sense the way they're reacting from the outside, but the person is almost blind to it because it's not really a memory in that way. It's just sort of experiential reaction. Like you can explain, I think, a lot of symptoms from that conceptualization of it.
Hmm.
We're learning so much about all that.
Yeah, absolutely. And I think another structure that's really important is the hippocampus. And we've mentioned memories and the role it plays in trauma, but these traumatic memories are kept in a nonverbal form.
Hmm.
And so the hippocampus is involved in encoding and consolidation of important memories, and it actually shows shrinkage in people with PTSD. And they first noticed this in Vietnam War veterans in 1995. And so when there's a lot of trauma, there is no consolidation of memory, but the nonverbal consolidation of this emotional memory registers. So you can't put words to it. That's why trauma takes away your words. If you can't put words to it, you can't understand it. If you can't understand it, you have no control over it, and then it takes over you.
Yep.
So the hippocampus is just really important to keep in mind. The reason we calm the environment down, calm the nervous system down, is so you can stop and verbally remember what just happened. A lot of kids will say, I don't know, I blacked out.
Yep.
Yeah, and those are the moments we really need to hunker down and create that calm environment.
And I think helping people put words to it can sometimes bring it to that more verbal intellectual place and allow much more flexibility to it. That's a lot of what we do in trauma. And this is not where you start, but a lot of what we do in trauma work is rescripting
Mhm.
and prolonged exposure and dealing directly with the trauma narrative to understand it differently. And you have to be in a safe space to be able to do that, to be able to make those changes.
Yeah.
Um, So, talking about some of the brain changes biologically that happen when someone experiences trauma, the increase in noradrenergic activity, which makes sense because it's adrenaline in other systems in the body. So, it's that sort of fight or flight response that gets hyperactivated and stays persistently activated, abnormal cortisol stimulant signaling, downregulation of dopamine and GABAergic receptor downregulation. There's no ability to calm oneself. And then there are different theories, and a lot of this is theory for the persistence of the trauma and why the experience remains so live, as opposed to becoming something that is more of an emotionally disconnected memory. So, one theory is the kindling hypothesis, which people may be familiar with from the concept of bipolar disorder. It's the idea that as something happens more and more frequently, it becomes easier each time or more likely to occur each time. So, some studies do suggest that repeated traumatic experiences, so people who have chronic small traumas or repeated small traumas, can actually experience those traumas more deeply than you would expect for any singular trauma. Unfortunately, humans are very good at efficiency. So, on the one hand, you would think that someone who goes through repeated traumas, you almost develop a resistance around that and you're more resilient. It seems like from some studies, quite the opposite is true. Your brain actually becomes more sensitized to experiencing trauma, and you're actually more likely to receive that trauma in a negative, impactful way. The more traumas you experience, the more likely you are to have PTSD.
Mm.
There's also the allostatic stress hypothesis, which is more the idea that almost like water wearing away at a mountain, that you would think that how can water impact a mountain? It's so soft, but over time it can dig a hole right through a mountain. So repeated traumatic experiences, even though each one seems small, does wear away at someone's resiliency and reduce somebody's capacity to tolerate those repeated stressors over time, actually making it more difficult to recover from each subsequent trauma. And then there's the truncated response view. This is closer to the idea of a scar, that your brain goes into a sort of hyperactive defense mode when you go through a trauma. Just like scar tissue is not normal tissue, it's not a replacement for skin. Your brain almost has a psychological scarring that takes effect and makes it more resistant to removing that trauma later. So, a normal extinction exposure or extinction response, you have a defense to, which is what makes trauma treatment so much more difficult than other types of CBT or treatment. I think a lot of people who know something about CBT, the classic example is you're walking down the hallway, you see your friend across the hall, you wave to your friend doesn't wave back, and you get all of these sort of automatic assumptions. You can sit down, you can look at that logically, you can go through what's the evidence for, what's the evidence against. With trauma, it's so activating and there's so much around it that going through those regular typical CBT exercises don't touch it. It's encapsulated in a way.
Yeah, I really appreciate what you're saying about the way that we view trauma is very, very different now, because in the past it's like grow thicker skin and get through it, get over it, right? Don't talk about it, just get through it and you're going to be fine. But actually, it doesn't work that way, because if you grow thicker skin, quote unquote, and then you get exposed to trauma again because you handled it fine last time, and you're more likely to suffer the symptoms of PTSD down the road because you never processed it. So I love that there's this flipping around that perception, but it is hard to accept, I think, depending on the age of the patients. So maybe older patients might feel like there's just no room for it, or maybe it's all somaticized. Everything is in the body, nothing is in the emotional space. And on the other end, nowadays, like everything is emotional, right? Everything has to do with mental health. So I feel like the balance beam has tipped over completely. But yeah, it's really crucial to mention that if you have more trauma, you're more likely to have negative consequences.
And that's actually a really important point that you make about different generations understanding, and that sometimes it feels like for younger generations, everything is related to mental health. What I don't want this to sound like is taking away someone's ability to move past trauma. That once you've experienced one trauma, the die is cast, and you are just more likely to have PTSD for the rest of your life, and there's not much you can do about it. This speaks to getting control of those responses and going into treatment and learning skills and sort of the capability of using those tools to move past the trauma that you've had, as opposed to saying, well, trauma's happened to me. Now there's nothing I can do about it. I'm just a traumatized person for the rest of my life. It's actually more of a call to action that there are absolutely ways that you can take back your power and your control.
Yeah, beautifully said. It's a call to action.
Yeah. And then there's the idea more globally outside of the individual person experiencing trauma of epigenetics. So this could be a whole talk in and of itself, but we now know that DNA is not fixed in that way, that in addition to genetic code that somebody has, there's methylation and there are other changes that change not the code itself necessarily, but how the code is expressed, sort of the signals on and off. And there seem to be, for populations who have experienced trauma, that actually impacts how subsequent generations' genomes are expressed. So it's the idea that trauma can be inherited by subsequent generations. So an entire population can be more sensitized to experience trauma. I mean, it's an extremely complicated way to view it. And I think we're still trying to figure out exactly what is relevant to the people sitting in front of us. But these are all theories and they come from our experience. And the experience that these theories would support is that people who go through trauma are more likely to experience subsequent traumas, and that people who go through trauma have a more difficult time recovering from the trauma that they experience. It's not the case that you develop a way of dealing with trauma and a knowledge base and a resiliency based on recurring experiences of trauma. Quite the opposite. That's why treatment can be so important. And even things like psychological first aid can be so important. And honestly, why organizations like the military are going into preventative treatment, teaching CBT and CPT before somebody is deployed and potentially exposed to trauma so that they have some skills to be able to address it as it happens, as opposed to just sort of hoping for the best, because we know that that doesn't always lead to good outcomes. And sometimes this trauma can even be passed down in generations themselves. So those are sort of the, I don't want to say negative, but those are some of the views of what puts someone more at risk for internalizing those traumatic experiences. But there are some protective factors as well. So strong social support, we know, is a strong protective factor. In fact, one of the elements of psychological first aid is explicitly connecting someone with their pre-existing social supports, plugging somebody into their network and fighting that urge to isolate. The converse is also true. People who have poor social supports are more likely to go on to develop acute stress disorder or PTSD symptoms after a trauma exposure.
Yeah. And the idea of a community, a social support network, is so crucial in preventing PTSD. And so I think it's important to recognize and highlight some marginalized and minority groups just to show the numbers that they're up against. So Black Americans, they have the highest PTSD prevalence among U.S. ethnic groups, which is 8.7%. LGBTQ plus individuals also face unique trauma risks, especially now. It's almost like dangerous to walk around the streets these days. You know, it's really heartbreaking. But up to 47.6% of LGB and 42% of transgender individuals report having PTSD. And then Indigenous people and refugees in the Western Hemisphere also have higher rates.
Absolutely. And there's migrant populations, refugee populations, because I think people in those populations in America are particularly under attack right now. But most individuals certainly experience some sort of traumatic exposure being from a marginalized or underrepresented population of whatever type. And the idea of where is my community is such an important concept to find. I think some racial ethnic minorities do have a built-in community through their family, through their community, but sometimes that community is not open to the idea of trauma, not open to the idea of mental health. Similar to the military environment, may have a negative view towards getting treatment and blaming of the person for not being strong enough to withstand the traumatic exposure. Whereas I think sexual minorities, LGBT, may start off their journey more isolated because they may not have similar individuals in their lives or in their family. But as a group, once they start building that for themselves, I think there is more of an acceptance and openness to the idea of mental health and treatment. And I think establishing that built-in community is such a critical and important point of treatment. And it's not part of treatment as we practice it, right? Someone doesn't come in to see us as therapists or psychiatrists and we say, oh, well, here are your friends. We're prescribing friends. Here's the friends that you'll meet. That's, everybody's own work to do. And that can be sometimes the hardest part, but honestly, part of the most important part.
That is such a great example. I wish I could prescribe friends, but I can't and I shouldn't because, you should pick them.
Right. Yeah.
And it's so interesting because it does seem like with military trauma, group therapy seems to be more helpful. I think there's just something about combat trauma that if you're in a room with people who have experienced similar things, it's just so validating, just the presence, right? You don't really have to say too much. You mention like one word or one buzzword or whatever, and they understand exactly what you mean. That community, sense of community, feeling like you're not alone, it's almost like AA in a way. That's what therapy is, you come in, you figure out who you are and what you are about, and then you form your community based on those values.
Well, yeah, I think that's a really important point. And, some people respond better to group therapy and some people respond better to individual therapy. So there is a question of fit to the young person's way of moving through that, but the evidence supports that. And I think part of that is that there is so much stigma in the military itself that everyone becomes an island. Everyone who's experiencing PTSD feels like they're the only person to go through that there's something wrong with them, that everybody else can just get through this. And so being able to build a community of people who have gone through similar things and responded in a similar way, you're right. It is so validating and it takes so much of the weight and the self-blame and the guilt off of it, probably like AA to a certain extent, that it can really move treatment forward.
Yeah, the guilt is a huge thing. Yeah, survivor guilt and the randomness of war, right? It's so hard to morally, ethically justify that in your mind. Moral injury, it really plagues people. That is not to take away hope, but just to say that it is a marathon, not a sprint. So I think there's also cross-cultural variations is something really important to know. Like hysteria is an understanding, right? Like this happens and it's part of the mourning process or it's part of the celebration of life. And some other cultures are very, very silent and quiet about that. And so I think that piece is also helpful in delineating, is this like a clinical pathological situation or is this something that the family has to go through to cope and they have enough support and community around that?
That's one of the strengths of something like psychological first aid is that it sort of respects that. It's not prescriptive in you need to talk about everything that's happened or you shouldn't talk about anything that's happened. It's getting people in touch with their own supports and their own ways of coping with it. It's helping someone heal by supporting their own healing mechanisms as opposed to trying to replace them. So in a way, it's culturally sensitive.
Yeah, we love these approaches that are universally, you can apply it in any situation, especially things like psychological first aid. It's a kit, it's a first
Mhm.
aid kit. Yeah.
Yeah, right. Sometimes I like to think of it through the medical model almost, that if someone has a physical injury, your body is already trying to get past it and trying to heal. And psychological first aid is really supporting that. If somebody comes in with a deep cut to the ER, you wash it out and make sure it's clean and let the body do its thing and support that and maybe dress it and protect it. But you don't sort of immediately go in and cut out the edges of the borders and do all that. You actually sort of respect it and let it move through its own healing structure. And I think that's psychological first aid. But if somebody comes in with a wound that's turned into an abscess, then you have to take the opposite approach. And you do have to do more invasive treatments. And you have to make sure to sort of pull that out and close the abscess space and dress it and do all of those things. And we'll talk more explicitly about the different types of trauma treatment later, but lots of people think either it's like a procedure, I'll get into treatment and I'll get past this and this will be behind me and it'll be done, which is not necessarily true. And other people think, I'm not going into trauma treatment. I'm having enough problems dealing with this myself. I'm not going to talk about it with someone. That's a terrible idea. And so much of trauma treatment can be more about building coping skills in general without necessarily even talking about the trauma explicitly. EMDR is one example of that. And there are evidence-based treatments that are non-trauma focused, like CBT, that are more directed towards building up skills in general that can help people regardless of how they got to be in the room in the first place. So for people who are not quite ready or not interested in a more dedicated trauma treatment, getting into some sort of treatment has evidence that it can be helpful at reducing symptom load.
Exactly right.
All right, we're going to wrap it up here for this episode. And tune in next time for the treatment of trauma, including psychotherapy and medications.